we're going to have 4 speakers talking about high-risk populations, and by no means do we mean that this is all that's known about the topic. It's really, as Alan has said, to try and get the community involved in how to deal with this problem of high-risk populations that we think are quite important in malaria transmission, especially at low endemicities. So without further ado, we'll get Adam Bennett to come up, and you can introduce yourself a bit further and then tell us about defining high-risk populations for targeted surveillance.
Afternoon. Thanks very much. My name is Adam Bennett. I'm with the Malaria Elimination Initiative at the University of California, San Francisco. And we have, as Rolly mentioned, we have been dealing greatly with programs who reflect upon us the common challenge that there are these groups of populations amongst them that are oftentimes hard to define and hard to target because they are both at high risk of malaria and also hard to potentially to access. And so I'm going to go through a bit of background on some of the ways this has been conceptualized, and then I'll also introduce some potential ways that we can think about conducting surveillance amongst these groups to identify and target interventions towards them. And I'll close at the very end with just a slide on some planned work that we have coming in the next couple of years to try and address some of these issues with some specific programs in different parts of the country, in different parts of the world. So as Alan and Rolly mentioned, so talking about defining high-risk populations, there's a couple of ways that this can be conceptualized. So as transmission decreases, we know that it becomes increasingly clustered. And this clustering occurs both geographically and within demographic groups. And so we can talk about the geographic clustering as clustering within hotspots. These are geographic areas where transmission rates are higher than average. And we can target these areas with specific geographically based interventions. But the more challenging group are these hot pops, so groups of individuals who are at higher risk of malaria, not necessarily due to where they live specifically, but due to behaviors such as working in the forest or traveling to certain areas. And we need to figure out ways to identify these individuals and to target them. And oftentimes this is one of the key challenges as transmission gets very low, because it's a much more challenging endeavor than just going to a household. So these high-risk populations vary greatly by region, and this is another big issue, is that there's no real general way to think about these, and we're trying to help move that discussion along a bit. But these groups vary greatly. They include a lot of individuals that are defined by risk factors due to occupation, due to behavior. These include farmers and fishermen, plantation workers, gold miners in many parts of the world, illegal and legal forest workers. So these are individuals who are occupationally or behaviorally spending times in places where they're more likely to get infected with malaria than the general population. And different types of these groups are present in different numbers in different countries, and so it's important that we learn how to define these, that programs and countries learn how to define these, because they're also very dynamic, and it's important that programs have ways to identify each one of these groups. So this is really very programmatically relevant, and so as we go around the world meeting with programs, we find this is one of the key challenges that comes up. And it's both because these individuals are more likely to be infected, but also because they are oftentimes less likely to access treatment for various reasons. They may be mobile and moving between countries, between regions, or they may be socially marginalized and have less ability to access due to distance to facilities, due to socioeconomic status and whatnot, or even language issues in much of the world. So what are the key questions that we as researchers and that programs have to answer to be able to identify these populations and to develop targeted surveillance strategies towards them? So first of all, what are the socio-demographic, occupational, and behavioral risk factors for malaria infection? Are there cohesive groups of individuals at higher risk? Or are these risk factors just randomly distributed through the population? Do they congregate in specific individuals? Can we quantify these populations at risk? Can we define them as a group and determine their size, determine infections rates amongst them, which is sort of a key facet of epidemiological investigation, is being able to determine the denominator and determine rates of infection or rates of intervention uptake amongst groups. And what are their travel patterns? So obviously we're going to talk a lot about mobility when we're talking about high-risk populations. How do they move? Do they move more subnationally or across international borders? What is their current use of preventive measures? Do they have a high knowledge of malaria or not? Do they have access to health services, or are they hard to access? And where, when, and how do interventions then need to be implemented to access these groups? And this is the crux of the matter for programs. How do they use this information then to decide exactly where and when to conduct interventions, and amongst whom, and in what language, and whatnot? So this is a very important point. And then there's also a lot of knowledge that's already out there, and oftentimes it's not well coordinated. So how can we integrate and update all the current knowledge that's out there about high-risk populations? So these are really the sort of a list of questions that we can think through as we go through my talk, and also through the others that will follow, about what programs really need to think about when talking about high-risk populations. And one way we can try and conceptualize this is to think about a couple different axes of how these different groups of individuals are organized, or can be classified potentially. And one of them is really there's different groups based upon mobility. So that's on the x-axis here. Excuse me. Is the mobility. So we have groups that can be classified based upon the amount of travel that they do, the amount of movement they do within countries and between countries, and how mobile they are. And additionally, how accessible they are. So how accessible they are to surveillance systems, to programs, and then how well they can access, in turn, the surveillance system, such as the passive surveillance system. And oftentimes these are, we think oftentimes that these groups are very hard to access, but oftentimes there are actually very easy access groups that are at high risk of transmission. So it's important to think about both the mobility axes as well as the access axes. So talking about mobility, so mobility is a and population movement is a well recognized facet and challenge to malaria elimination and eradication, and has been recognized since the first era of malaria eradication. Note the date here from the 60s. This was the end of the eradication era, and it really a recognition that what's challenging for programs is really the fact that we have all these populations moving due to seasonal migration and whatnot. And it's important for programs to be able to identify how to tackle this challenge, and this is really a long-term challenge. There's been some nice recent documentation of ways to think about mobility, and think about mobility in terms of either the spatial component of mobility or the temporal component of mobility. And so if we think about these two axes, and this was published by Pendolia and colleagues in Malaria Journal a couple of years back, and what how this can help a program is it can help them to recognize that there are specific groups of populations who are mobile, who are at higher risk than others. And those are the ones that, when they come into a country or come into an area, are very important to be able to track and investigate and follow up and hopefully treat. One example are seasonal laborers who move between international borders and can be big importers of infections across borders and prevent a problem for elimination programs. So recently we've learned that the Sri Lankan program is very close to eliminating, has not had a local case of malaria in the last couple of years, but they are still vulnerable to importation from a number of migrants, and they've done some work to investigate where these migrants are coming into their country and where they're coming from, and really then done targeted surveillance and response amongst specific individual migrants. And so, for example, here they found that a large proportion of them are from Pakistan, and so they now do targeted screening and treatment amongst Pakistanis at the border. So here's an example of a highly mobile population from an endemic country, but that's actually can be easily accessed because they're coming through formal borders in this case. There's other cases where these might not be as easily accessed, and we'll talk about that in a couple slides here. So what we're working on currently going forward is generating some new evidence for targeted surveillance. And we're doing this through collating information on what is already done, so not to sort of come up with a blank slate, but to realize that this has been considered and talked about amongst programs for 50 to 60 years, and to use that information that programs know from their populations to update our current understanding. Also to develop tools to help programs identify risk factors, and Jenny's going to talk about this a bit more in her talk. And this is through the use of a case control type tool that programs can use to identify specific risk factors, and then the use of social networks. So for these very hard to reach populations, the ones that we can't access at border crossings or can't access in specific places, we can try to use social networking strategies to access them through their networks of high-risk individuals, or through venue-based surveillance, so actually going to specific places where we learn that they congregate through formative research and whatnot. And so I'm going to talk briefly about the second two methods here in the next couple of slides. So identifying risk factors through case control studies. So case control studies are well known in epidemiology and used in many different disease settings. However, they've actually not been used very frequently in malaria to identify risk factors. And this is something that we are currently working on using to try and identify some of these risk factors that we can then integrate into social network type targeted surveillance activities going forward. And there's a couple different ways you can do this. One of the easiest ways is through the passive surveillance system. So for easy access individuals who are able to get to the facility, we can conduct case control studies by selecting those cases and then matching controls, and Jenny will discuss this further. But then also active case detection potentially, so community-based cases and controls are also important to consider to figure out risk factors. And then once we know risk factors, we can follow up specific cases at facilities through identifying cases and then finding those cases that are potentially at a higher risk and trying to identify their network, or so individuals who may share similar occupations, similar behaviors, and so we may find additional infections this way. So, as an example here, finding a new positive case by linking between these individuals, and this is something that's been tried with and succeeded in some settings, but has some challenges in others. I'm going to talk a bit more about those. We can also talk about venue-based sampling at places where individuals congregate, and so this might be bars. So, for example, bars, oftentimes individuals who go to bars in malaria endemic areas are oftentimes out in the evening, for example. So they're out when mosquitoes are more likely to bite. So we can potentially try to sample some of these locations to try and identify more high-risk individuals that way. So talking specifically about the social networks aspect, so there's several different ways this has been done in other disease settings, and Jerry will talk a bit more about this. A lot of this is borrowed from the HIV world, where this has been done to this type of methodologies have been used for conducting surveillance amongst injection drug users and whatnot, and those who have high risk of HIV. And so the idea behind snowball sampling is basically using networks and sort of using peer referral to identify groups of individuals who share specific risk factors, and then both to access them, but also then to conduct surveillance and potentially deliver intervention through these potentially hidden or hard to reach, although not necessarily hard to reach, populations through social networks. And then, but this is not it's not a population-based approach. It's really a formative assessment used to identify if social networks exist. But once social networks are known to exist in this setting, we can use more probabilistic approaches such as respondent-driven sampling to actually identify specific characteristics of the population and to develop estimates around prevalence rates and estimates around intervention coverage that are that are representative of that population. And this requires a few more steps than just snowball sampling. And we'll talk about that in Jerry's talk. And then, so for those that are more easy access, so easy access groups, we can use time location sampling. So this is specifically sampling individuals that are potentially high risk at certain times and locations. And this is potentially very relevant for malaria because obviously malaria is a very spatially and temporally specific disease, and the risk is very spatially and temporally specific. So can we identify individuals who are in locations and at times when they might be infected and thereby identify them? This includes targeted border screening like Sri Lanka is doing. It includes potentially institutional sampling. So this means like potentially sampling at plantations or at companies where large groups of migrant laborers might be working, but also at markets and at bars. But oftentimes multiple different strategies are necessary to get a full picture, to get the full contextual picture for different groups in one area, in one country. So just a quick example of some studies that have been done in the HIV world. So amongst a study that was conducted on the border of U.S. and Mexico, using RDS to try and look at syphilis rates and to identify syphilis rates and HIV rates amongst populations who were injection drug users, self-identified as injection drug users in this area. And you can see the dark spots here are infected individuals, and you can generally see that there are higher rates of infected individuals sort of following what these initial seeds. So at the top, basically the way this process works is you have initial seeds, and then each seed is asked to recruit a specific number, so a limited number of individuals, and then they themselves bring in new individuals who then recruit more, and this way we're able to produce a population-based estimate amongst this social network. So this has been used in malaria, actually more recently, in Swaziland through some formative work using social networking. So Swaziland sits on the border with Mozambique, and so Swaziland is achieving elimination as we speak, but is challenged by having Mozambique on its border, which is a much higher transmission area. And there are a number of migrants who come into Swaziland to work on sugar plantations. And so what this study showed was that we are able to identify, and the program is able to identify specific individuals who are traveling between these areas and identify specific locations and times where they meet. And this is really something that a program then can use to conduct targeted surveillance amongst these individuals and to do interventions. However, there was no parasite testing conducted in this study, so don't actually know their specific rates, but we do know their rates of risk factors. RDS studies have been actually done in a handful of places in Southeast Asia where there's a lot of challenges around high-risk populations, and this has been used to try and develop population-based estimates of the specific individual groups of migrants, such as those that are more long-term migrants or shorter-term seasonal work. And this has been done on the Thailand-Cambodia border. And they recognized that they were able to actually identify distinct groups who would have otherwise been hard to identify through the surveillance system. They were able to identify these individuals, find out that they were actually socially networked, identified as such, and therefore was a useful surveillance and a recruitment tool to learn about these populations. So in Cambodia, and Sarah's going to talk a lot more about Cambodia, so I won't spend too much time here, but RDS has been used a great deal in Cambodia, in the Artemis and the resistance zones, to look at specific groups of populations that might not be located through formal methods or ordinary methods of household surveys, for example. So here's basically a comparison of RDS studies on these two colors. And then this is basically a more of a household community-based survey approach to look at ITN ownership, knowledge of mosquitoes, whether individuals were treated in the public sector or in the formal private sector or in the informal. And a couple of things that come out from this, you notice that ITN ownership, so access to interventions, was much lower in these high-risk populations. Mosquito knowledge was pretty similar. While treatment in public sector was greater, the treatment in the private formal was much lower. But the treatment in the private informal sector, which oftentimes does not report as much, is much more loosely affiliated with the program. the control program, there was much more attendance of these individuals there. So this is an important thing to recognize. These individuals might need this type of strategy because they're not accessing the formal passive surveillance system as readily. So just to conclude and talk about some additional considerations. So high-risk populations they're a key challenge for malaria elimination programs. A greater understanding is still needed because while we've presented some sort of general overview here, there's great diversity and heterogeneity within each country, and we'll learn about a few of these in the next couple of presentations. We do have a number of strategies for identifying and accessing these high-risk populations, but certain assumptions need to be met in order for these methods to be useful. Additional considerations, as I touched on in the last slide, are that we need to learn about how best to involve the private sector in these activities. Oftentimes, a lot of these individuals are going to private sectors. And also to monitor concerns about stigmatization. This has been a big problem in HIV worlds. Malaria is not as stigmatized in general, but we don't want to create a problem through identifying these groups as high risk and talking about them as such. So some of our planned activities, just quickly. So we have ongoing and planned research in some areas where these populations are a concern. These include northern Namibia, where we're planning active surveillance activities through peer referral, similar to what I mentioned in Swaziland, but also using PCR parasite testing, and then venue-based sampling. So actually going to bars and fishing areas in northern Namibia to try and identify high-risk populations there. And then similarly, there's a big problem of forest going in Vietnam, and we'll be working there in the next year or two and trying to help identify who these individuals are, how networked they are, and how do we actually target them and conduct interventions amongst them. So with that, I'll say thank you to my collaborators, the Bill and Melinda Gates Foundation, and colleagues. Thanks very much.
Shall we take a few questions now, if anyone wants to ask any questions, or we can move on to the other talks? And just to say, there's some chairs for those people sitting at the back. There's some chairs here at the front, this side. There's quite a few empty chairs.